Good evening. My name is Dr. Dareen Siri. We are beginning this CME talk called Improved Assessment of Severity and Novel Management Strategies to Alleviate the Burden of CRS with Nasal Polyps, also known as Chronic Rhinosinusitis with Nasal Polyps, CRSwNP. This activity is provided by Integrity CE LLC. It is jointly provided by the Global Education Group and Integrity and is supported by an independent medical education grant from Regeneron Pharmaceuticals and Sanofi. Next slide, please. In terms of how to obtain CME or CE credit, to receive CME credit for the participation of this live webcast, participants must complete the pretest, view the program content, complete the post-test and evaluation form, and a link to the post-test and evaluation form will be provided at the end of the program. Your certificate will be processed and emailed to you within 4 weeks after receipt of the completed forms. Next slide. Again, my name is Dareen Siri. I'm assistant professor of otolaryngology head and neck surgery in the allergy subdivision at Southern Illinois University School of Medicine. I'm also the chief executive officer of Midwest Allergy, Sinus, Asthma, and Sneeze, Wheeze, and Itch Associates Clinical Research in Bloomington Normal and Springfield, Illinois. And I'm going to introduce to you my co-presenter, Dr. Amber Patterson. If you would like to introduce yourself, Dr. Patterson.
Sure. Thank you, Dr. Siri. I'm a clinical assistant professor at the College of Medicine, University of Toledo in Toledo, Ohio, and also founder CEO of my private practice, allergy immunology practice, Ani Allergy in Findlay, Ohio.
Fantastic. These are our disclosures, which you can review at your leisure. In terms of the learning objectives, first, we're going to discuss how to apply evidence-based guidance to assess the severity and quality of life impact of CRS with nasal polyps, also known as CRSwNP, describe how to incorporate current guidelines and expert recommendations into the positioning of biological therapy, sinus surgery, and corticosteroids, including oral and topical, for the treatment of patients with CRS with NP. And we will summarize clinical trial data on the efficacy and safety of biologics and surgical options for patients with CRS with NP. Next. So let's go over the disease burden of CRS with NP, which is surprisingly quite high. In terms of the prevalence of chronic rhinosinusitis, those who have additional nasal polyposis, and certainly those who don't have evidence of any polyposis, it is quite a significant impact. It's 11.6% of the total population. This is based on the CDC, or Center for Disease Control and Prevention survey. And so you can imagine that there are certainly a fragment, a small proportion of adolescents who are undiagnosed. And these, of course, are from ICD-10 codes and diagnosis. So there's certainly many patients who go under or undiagnosed. There are certainly many of us in this allergy immunology realm where we initially treat them for allergic rhinitis. And in essence, they don't improve. And so those patients are also unidentified CRS with nasal polyps or CRS patients as well. We can see here that about 20% of those patients do have identified nasal polyps, nasal polyposis, polyps in evolution. Next. So what are the classical features of CRS with NP? Certainly, these can be time limited. Usually, if the patient has this for at least 12 weeks, we can be confident of the diagnosis. Less than that, we can be a little bit less confident, but certainly there are sinonasal symptoms that are important. Patients often complain of what they perceive as a sinus headache, facial pain or pressure, particularly if it's anterior, but some patients will have other forms of headache as well. They will have nasal discharge. This can be out of the front of the nose, which we describe as rhinorrhea. It could be down the back of the nose, which we describe as postnasal drip. And certainly there's an impact of the sense of smell. Either there's loss of sense of smell, a perception of loss, or a reduction of sense of smell. There's also nasal blockage or congestion. And then other nasal symptoms can occur as well, especially if there's mechanical issues. There can be a little bit of epistaxis that can occur, things that are being applied to the nose, etc. And patients have significant extra rhinological symptoms. Some of them may cough. Some of them may have other things that are involved. Comorbidities we're going to talk about. There's certainly an impact on quality of life. There's disrupted sleep, poor sleep quality. There's a social impact to these patients. Fatigue, tiredness, energy level. A lot of them describe this brain fog. A lot of them are depressed or anxious. They are sad. They're moody. They're frustrated. They're restless. They have irritability. There's a lot of tension. And certainly there can be issues with productivity at work, absences from work, or what we signify as being at work and things are not doing so well. And certainly patients may feel embarrassed because they are using tissues. Sometimes they feel they're chronically sick. Sometimes they think they need antibiotics. Sometimes they think they have a viral infection all the time, also feeling fatigued. And so certainly they may even feel like they're infectious. This impacts them socially, personally, at work as well. And, if you can imagine the times that you felt when you were congested, when you actually did have a sinus infection or a cold, but those symptoms continue to linger, the congestion, the difficulty sleeping, the headaches, the inability to breathe out your nose, the mouth breathing, etc., and all those things that go along with when we feel sick, even for a day or 2 days or 3 days, but you're feeling this throughout the year and certainly for 12 weeks or more with some of those cardinal symptoms such as facial pain pressure, discharge, sense of smell issues, loss of taste as a result, and congestion, that I think that most of us would be quite moody as well. Let's go to the next slide. So as we do this comparison, this is the best ability to think about how burdensome this disease is. And little attention has been paid to it until now. And so certainly these patients with CRS, with and without nasal polyps, but certainly with nasal polyps a little bit more impactful, is that their quality of life as measured by SF36 is quite burdensome, including on par with those who have type 2 diabetes, rheumatoid arthritis, and even asthma. And you can see here how they rate in terms of that quality of life scale on a very similar platform. Of course, the best you're feeling being close to that 100% mark in some of these scales, such as the EQ VAS score or the visual analog scale, the SF36, of course, maximum scores being 60. And so you can see here that their quality of life can even be lower than some of those other chronic diseases. Next. So patients do report unmet needs in CRS with nasal polyps. In this study, in which they did one-on-one interviews with 15 patients with CRS nasal polyps to identify those unmet needs, certainly they talk about the burden, how their daily lives are impacted, and impacted in a very wide way. And certainly we talk about also those extra nasal symptoms. They're frustrating aspects of the disease. Of course, sleep impact, inability to fall asleep, waking up in the middle of the night, having problems when they are breathing out of their mouth, feeling that dry mouth. Certainly it causes mental dysfunction. And if you don't have good quality of sleep, certainly your daytime will be draggy and you may even fall asleep. Some of these patients actually are misdiagnosed as having sleep apnea, but certainly some of those patients have concomitant sleep apnea. There's an underestimation of the burden of CRS, and some people do confuse this with allergic rhinitis, which is in itself a chronic unhealthy disease. But at the same time, these patients are the same patients that call your office repeatedly, that are calling your office on Friday afternoon asking for antibiotics, some measure of relief, corticosteroids repeatedly, because that's the only thing they found helpful. And so you see that these patients have a higher impact on our practice as physicians because it is much more impactful for them at home. And certainly they feel incredibly frustrated and also frustrated about the lack of adequate options up till a certain point. The psychological aspect being very important in terms of the mental health. And so this is often forgotten as well. Next. So if we can coordinate their care, work together, allergists, key stakeholders, ENTs, primary care doctors, hopefully we can address some of these first in recognition of their problem. Many patients, again, may present to the clinic with repeated sinus infections, or they may present as allergic patients. And if we can have this high index of suspicion that they have CRS potentially with nasal polyps, then we can order the right diagnostic test to get them appropriate treatment. Next. And so there are many positive effects of sinus surgery. We know that. And there's certainly many positive effects of oral corticosteroids. But just with any therapy that's interventional, and just with anything that may be unhealthy in the long term with repeated use, then we do have to have that stewardship. And this does come with limitations in terms of patients who have recidivism, and they have the need to have repeat either surgical intervention or corticosteroids. So they may have some disappointing outcomes. So we are looking for safe, effective therapies that maintain the patients in the long term, that perhaps they don't have to have repeated interventions that are invasive. Next. So let's go over the assessment of disease severity and the quality of life impact. We're going to build through these slides real quick. There are really no perfect measures of evaluation of CRS with NP. These are various ones that have been produced. And again, some of these have been validated not too long ago because of the need, because there's an unmet need to quantify and qualify how bad our patients are, and certainly also to quantify and qualify any impact of treatment that we might apply. So some of the clinician-reported measures may be a nasal polyp score. That's a visual indication of how bad their nasal polyps are. Some of these are radiographic in terms of that Lund-Kennedy or Lund-Mackay CT score. There are patient-reported outcomes, such as the sinonasal outcome test, very popular 22-point rating scale in terms of quality of life. Nasal congestion score, which is a classic congestion of mild, moderate, severe score. There's a sense of smell test, and there are a variety of tests, the most popular being the UPSID or the University of Pennsylvania smell identification test, and certainly some other surveys along that line that are listed below. And then, of course, the patient-reported measures of their overall well-being, not just specific to nasal symptoms, such as the SF-36 and the Euro Quality of Life 5-dimensional score as well. Next. So here we see with SNOT 22, as we delve a little bit into the details, a 22-item disease-specific validated PRO measure, patient-reported outcome measure. The key diagnostic symptoms include things that are, often that are reported by patients: nasal blockage congestion in the key diagnosis of CRS with nasal polyps, sense of smell or taste, thick nasal discharge, the need to blow their nose, post-nasal discharge, and certainly along with other items that are very important in terms of identifying disease. Any value greater than 50 of a total of 110-point score on this 22 question scoring is actually significant. And the minimally clinically important change is about 10 points on the SNOT 22 scale, if you didn't already know. So this is a very suitable tool for practice. It's fairly easy to use, but it does take time to administer. And it is increasingly used to measure therapeutics, but also quality of life in a clinical practice as we're walking through our patients' symptoms. Next slide. Another indication is that visual indication, the nasal polyp score, and this must be done by nasal endoscopy. It is difficult to do alone just on anterior rhinoscopy with a simple speculum. We might be able to see some of the larger, more moderate or severe polyps at that grade 3 or 4, but certainly this requires endoscopy, which is not difficult to do, but this is limited to mostly ear, nose, throat surgeons and maybe some allergists as well, and other people trained as such. So what you're visualizing here is the polyp size and location. So if you imagine that this is the patient's right side, and of course we're on their left side, so we're visualizing on the left, and that worm-looking object is the free space in that right side of the nasal cavity. Those two bumps in there are really the inferior and the middle turbinates, and then the gray parts are the nasal polyps that have essentially been a foreign body extruding into the space of that free cavity. So here on the left with 0, we have no polyps. 1 is basically small polyps, and it does not pass past the middle meatus, the inferior border, the middle turbinate. And then we have 2, which does pass the inferior border of that middle turbinate. And then, of course, we have larger polyps, which reach the lower border of that inferior turbinate, as well as even larger past that as well. And so some of our patients have very significant disease burden, and sometimes it's very obvious even from across the room that there is a score that it should be higher than 4, but that is the limitation of the scoring at 0 to 4. And this nasal polyp score is used in the majority of clinical trials when we're assessing therapeutics. There are some other clinical trials that use a 0 to 3 score. However, this one is the most popular one. And so certainly we would sum them both left and right side, and the total maximum score here is 4. I apologize, 4 on each side, total of 8. Next slide. So when we see evidence of type 2 inflammation, there certainly are a lot of comorbidities. We have to consider this when we think about our patients. Certainly most patients, if not all patients with CRS and with nasal polyps, really do deserve a yearly spirometry to screen and assess for asthma. There is a significant proportion of patients who have comorbid asthma, almost 2/3. Many of them also have allergic rhinitis or evidence of allergic rhinitis, and many of them have evidence of atopic dermatitis. The green, orange, and blue bars will differentiate differentiate mild, moderate, severe in this study, but you can see here that there's a lot of evidence of type 2 inflammation, which is in contradistinction to previous remote teaching in which we would think of patients with nasal polyps as not having type 2 inflammation. We thought that they were non-type 2. And in fact, the majority of patients who have nasal polyps have been demonstrated to have type 2 inflammation along with these other comorbidities. And of course, treatment of these comorbidities is also important. Some of these may exacerbate the nasal polyps. Some of them may track or go along with the nasal polyps. And some of them certainly basically may be a result of perhaps maybe with this allergic milieu, such as triggering of asthma. So certainly we need to consider these and their negative impact on the health-related quality of life as well. Next. So what are the key indicators that this is a type 2 inflamed patient? Certainly, we think about the comorbidities, as we talked about. Patients who have a tendency to have later onset asthma are typically type 2 inflamed patients. Patients who've had tissue eosinophilia on histology, if they have a bunch of eosinophils, eosinophilic mucin, Charcot-Leyden crystals on that biopsy or from that tissue histology from a previous ENT surgery, certainly those are type 2 inflamed patients. Those who have a tendency to have aspirin or non-steroidal anti-inflammatory agent exacerbated disease, which we call AERD. And certainly there may be some biomarkers, not perfect, but tissue eosinophils, greater than 10 per high power field. Blood eosinophils, this is in the normal range of 150 cells per microliter, but at least if we know that it is 150 or greater, it at least does not argue against the fact that they have type 2 inflammation and certainly a total IgE level of 100 or greater. There is an interesting paper that discusses that patients who have non-type 2 inflammation, more like cystic fibrosis type patients, their average blood eosinophil counts are usually less than 150, even if it's slightly less. And those patients who are worse, who have both type 2 inflammation and cystic fibrosis, have a tendency to have higher rates of respiratory disease. So these have been validated over time. And despite that blood eosinophil count being in that normal range, at least, again, it does not argue against that they do not have type 2 inflammation. So they may be helpful in your diagnosis of this patient because we do have to endotype them and phenotype these patients to offer them appropriate treatment. Next slide. So speaking of treatment, let's go over the current treatment landscape. Next. These are our classics. You have tried many of these. You've tried them in combination. This is a dynamic process. We, of course, have saline irrigation, a very, very popular treatment. Whether or not we put medications into that saline irrigation, very helpful. And we usually purport that this is helpful every single day in our patients, if not multiple times. On top of that, we want to suppress the inflammation that is unnaturally occurring. So, of course, we will start with intranasal corticosteroids, which are very helpful. There may be some other adjunct medications that may be helpful intranasally just with some symptoms. And oral corticosteroids, extremely helpful. However, we need to be good stewards of that, and excessive use may have harmful outcomes. So we are judicious on that use, and certainly that is not preferred in any scope of the imagination, but sometimes we do need to resort to it. Or if we need to debulk the patients of really severe disease, that is helpful. Of course, sinus surgery has been the mainstay. If we feel like we can open up the airway immediately with surgery, then the patient feels gratified. There's immediate relief. This is most effective in those with mild to moderate disease in terms of that persistence of effect. Those who have moderate to severe disease or a lot of evidence of T2 inflammation or a lot of other comorbidities have a tendency to, again, have recalcitrance, and they will have repeated issues. So we can go over that in the next few slides. And of course, the advent of biological therapies, of targeted, precise treatments for inflamed patients of specific types of inflammation really has been helpful to those patients who have failed traditional therapies or in which those therapies are either contraindicated or just not optimal. Next. So one of the treatments, of course, when we talk about intranasal corticosteroids is this unique device called the exhalation delivery system. It is fluticasone. It is in a unique device. It's breath powered. It's powered by closure of the soft palate when you blow into the device, and by pressing, you're able to expel the medication into the nasal passages and entrain that with the breath activation out of the other side. So there's the feeling and belief and demonstration that the medication of corticosteroids is actually delivered high and deep in areas that traditional intranasal corticosteroid sprays do not reach. And so we will look at the next click over, and this is a pooled efficacy of EDS or exhale delivery system fluticasone from the randomized controlled Reopen 1 and Reopen 2 duplicate parallel phase 3 clinical trials. The co-primary endpoints were number one, this CSS, which is the composite symptom score of various domains, including things like congestion, and number two, sinus opacification, as demonstrated on a CT by Lund-Mackay score and other scoring systems. And you can see that there is a treatment difference from both the composite symptom score and the sinus opacification and reduction of that, and also demonstration of reduction of nasal polyp burden by nasal polyp scores on the medication with monotherapy versus placebo. So here is the pooled safety data of EDS flu, adverse events occurring in greater than 3% of patients and more common in those than, of course, the placebo group. And again, the placebo was a vehicle placebo, which means that the vehicle in which EDS flu is actually contained was administered to those placebo groups. So they weren't spraying air. Of course, I'll have to remind you of that. And then these are the composite safety data, which is epistaxis, which occurs a little higher, especially in the higher dosage of 372 micrograms per spray. And then COVID-19, headache, and of course, nasopharyngitis, but still fairly effective and a fairly safe medication. Next. So in terms of risk factors for nasal polyp recurrence, we talked about those surgical patients where, it's optimized. Many people believe that all patients with substantial burden, a moderate burden at least, of nasal polyps should at least have one surgical intervention. And in some of the mild to moderate patients, certainly that fixes the problem and then they do not recur. But these are the things that we look at thinking about those patients that have to come back, that may have a recurrence, that may need surgery long-term. That includes asthma, those patients with aspirin exacerbated respiratory disease, those patients with allergic fungal rhinosinusitis, those patients who smoke, those patients who have high burden of allergy, those type 2 inflamed patients, certainly patients who've had prior surgery, and those patients who are a bit younger. And it's upwards of 50 to 75% of patients that actually may have recurrence over time, including at 3, 4, 5, 6 years, etc. So we want to think about, again, the endotyping, the phenotyping of these patients and think about their risk profile after that first surgical intervention, along with our concomitant treatments, because of course we're not treating them just with surgery alone. They're not in a silo. And then to see if whether or not these patients will have a good long-term response to consider additional therapeutics. Next. So as we talk about the additional therapeutics, these are the approved biologics at the current time of CRS with nasal polyps. Dupilumab, you're familiar with. Omalizumab, you're familiar with, and mepolizumab, you're familiar with. The targets, of course, are noted, interleukin 4/13, IgE, or immunoglobulin E, and interleukin 5. And these are the indications. They are all an add-on to standard of care maintenance, which clearly is an intranasal corticosteroid. And if you feel like maintenance or standard of care is also saline irrigation, it would be added onto those. And these are varied, but dupilumab is indicated for adults and pediatrics greater than 12 years of age, and omalizumab and mepolizumab at the current time indicated at age 18 years and up. The dosing schedule is noted on the right. Next slide. This is a very interesting paper in which they did a comparative effect of biologics as well as aspirin desensitization in those patients with CRS with nasal polyps. And this is not a head-to-head data. They aggregated the information from the different pivotal clinical studies in terms of these outcomes, the quality of life, SNOT-22, the VAS score, the SMELL, University of Pennsylvania smell identification test, etc. And so then they took that information from each of those clinical studies and clinical trials and aggregated them together so we could try to compare perhaps apples to apples if possible. And again, not a head-to-head trial, just aggregated data from the clinical trials to basically look to see what the outcomes were. And you can see here that highlighted in green are those that seemed from this panel of experts to be the most beneficial, some with immediate benefit in the lighter blue colors, and of course in the teal colors, those that are less beneficial and not clearly different from placebo necessarily. And there was one standout that was harmful, and the harmfulness based on adverse events. So if you look at this in detail, which at some point you will be able to pull this paper hopefully and look at it, you can see that at least, for example, SNOT-22, the biggest outcomes being with dupilumab, omalizumab, and the smell identification test, the biggest impact being with dupilumab, reduction of oral corticosteroid use for rescue during the clinical trial, the biggest reduction with dupilumab, but also moderate with omalizumab, and certainly rescue polyp surgery if the patients needed it, thereby looking at then dupilumab, and of course adverse events, that one being the highest with aspirin desensitization. This is largely due to gastrointestinal upset and sometimes even gastrointestinal bleeding because of the level of aspirin required to suppress growth of those nasal polyps. There's a nasal polyp size reduction on that 0 to 8 scale with -2 points with dupilumab and -1 on both omalizumab and mepolizumab. And certainly the CT score, the Len-Mackay burden score in terms of that clearance. And so that area where there is no data obviously remains blank and unpopulated. Next slide. So what about endoscopic sinus surgery? How does that compare to dupilumab, which was at the top of that previous paper? And so there's not much data in terms of that comparison, but this one tried to do that. And so they looked at this and said, let's look at the studies and compare these cohorts at 12 months of treatment. So this was a matched cohort study of endoscopic sinus surgery versus dupilumab. Patients undergoing endoscopic sinus surgery, of course, had greater improvements in that nasal polyp score. And patients also treated with dupilumab had a greater improvement in the SNOT-22 domains as well than in those patients with endoscopic sinus surgery, and the olfaction as well. However, the overall SNOT-22 score, there was really no main difference. I would say that certainly the endoscopic sinus surgery has a more immediate effect because, of course, there is debulking immediately of those polyps. But certainly the SNOT-22 score is probably not too terribly different when you look at them overall. But in some domains, one was a winner and one was not a winner. So endoscopic sinus surgery did have some superior improvements in those patients when we did a comparative analysis and not a matched cohort. And certainly, again, as we talked about, greater reductions in polyp size compared to some of those biologics. But again, there's very little data to do a direct comparison with biologics and surgery. And again, I do not feel like these are incompatible. You can do surgery and chase it with a biologic. So certainly this may be a moot issue. Next. So in terms of real-world efficacy of biologics for CRS with nasal polyps, this is the improvement of real-world outcomes with biological treatment of CRS with nasal polyps. And you can see there the different domains that are indicated and those real-world studies in terms of looking at, for example, some of those extranasal symptoms, asthma control, asthma exacerbations, and then, of course, overall quality of life. Next. So how do we select treatment in our patients with these various therapeutics? In order to select treatment, we do have to define our therapeutic goals. So this is the best effort at this in terms of EPOS 2020, and certainly Euphoria, which basically is an organization that is invested in respiratory diseases. And they both came out with position statements and papers. Obviously, these are European driven, but can be applicable to the North American population as well. In terms of what are we looking at? First, we want to achieve control. We want to have as close as possible to absence of symptoms, and hopefully we can do that rapidly in the next 30 days or so. And then long term, in the next year, we want to see if there's remission to try to control those symptoms as much as possible, either with ongoing intervention and treatments or perhaps with not ongoing interventions, treatments such as a surgery, and then looking at the patient down 12 months. And then long-term, 5 years or so, have we sustained remission in that patient? And then that means minimizing some of the treatments, maybe being on some of the treatments, and maybe not needing additional therapies such as resurgery, corticosteroids, et cetera, and things that we feel are invasive. And hopefully with a goal for some of these patients being off most of their treatments if possible. So those are great goals to be defined. Next. So as we do that, the American College of Allergy, Asthma, and Immunology also came out with a yardstick for the medical management of these patients. Certainly patients who have identified with symptoms of 12 weeks or more, which fit to that category of CRS with nasal polyps or CRS. We're going to click through some of these recommendations here. In terms of first line, of course, this is ubiquitous, widely available. We're going to go with intranasal corticosteroids. And certainly if this is not appropriate, the patient is not achieving what they need to achieve, even with maximal dosing, we may consider change that mode of delivery, such as with the EDS flu device. Concomitantly, we would do nasal irrigation because of what we feel are the benefits of course, nasal douching in these patients, and perhaps even adding some medications into that irrigation. We will attempt to phenotype and endotype the patients, as we discussed, by history, by looking at comorbidities, by looking at medication response or non-response, imaging, endoscopic findings, histological findings. And then we'll arrive at this diagnosis of CRS and if with nasal polyps, perhaps the first intervention in those patients who obviously have failed nasal irrigation, intranasal corticosteroids alone, whatever the method is, then they will consider functional endoscopic sinus surgery with removal of those polyps, perhaps addition of biologics, and intermittent pulse oral corticosteroids, which again should be limited to use, not used as chronic therapy, and certainly anything greater than 2 a year would be considered inappropriate. And then on top of that, looking at these patients with aspirin exacerbated respiratory disease, those patients may represent a unique subset, the specific different phenotype, still having type 2 inflammation, but certainly being sensitive to aspirin or nonsteroidals, and perhaps at a higher risk for recidivism, and certainly perhaps an intervention more soon with biologics. Next. Perfect. So as we're looking for escalation of those patients with refractory disease, those patients who after sinus surgery, we have some postoperative management, we might have some nasal saline irrigation, etc., and they will continue to have symptoms that persist despite this. What else can we talk about? And this, of course, will be a shared decision-making tool, guided shared decision-making, because we, as experts, know the information and can offer the patients a very valid evidence-based approach with discussion of safety and risk benefits. So here on the line, and these are not in specific order, but we can consider biologics, especially if they have other comorbidities that may benefit, such as asthma, or assessing that response in 6 months. Perhaps they require a revision sinus surgery. And again, this depends on how many sinus surgeries they've already had and what needs to be done. And that would be in the hands of our colleagues, our ENT surgeons. Aspirin desensitization. This is a little bit less optimal because of the data that we just saw, because of the risk of higher adverse reactions, but certainly there may be a benefit to those patients, particularly if they're older, if they do require aspirin therapy, they have concomitant cardiovascular disease, etc., or if they somehow need also nonsteroidal treatment long-term. And again, we would assess that response 6 months or sooner if needed. Which hasn't been mentioned yet, corticosteroids, and then this is a steroid sinus implant, which can be launched into the nasal cavity for a period of time. And this may be an effective way to deliver topical medication with less burden in terms of systemic need, and certainly short courses of oral corticosteroids for rescue. And again, this would be not optimal, but sometimes needed. Next. So then in a minority of patients, we might skip the sinus surgery because perhaps there is a contraindication. Perhaps they have platelet therapy they can't come off of, other risk factors, etc., uncontrolled asthma, poorly controlled asthma, etc., and perhaps they have declined surgery in terms of that shared decision-making, in which we can jump to some of these other treatments sooner, including consideration of biological agents. Next. So in terms of the indications for biological therapy, I think need for systemic corticosteroids frequently 2 courses or more. Certainly, they may have a contraindication, other comorbidities that preclude us from wanting to use more systemic corticosteroids, such as diabetes, hypertension, cataracts, etc. They have a significantly impaired quality of life. They have a significant loss of smell. They have comorbid asthma and perhaps some other comorbidities of the respiratory tract that may be benefited by a biological therapy, or even things that are type 2 and inflammatory diseases that are outside of asthma. And then perhaps some of those biomarkers could be helpful, including medication response and history of systemic corticosteroid exposure in their lifetime. And so perhaps some of these other things, diagnostics we would need to assess that, such as the SNOT-22, the UPSIT test or smell test of some sort. And certainly, as I stated before, all patients with CRS with nasal polyps in particular should be screened for asthma and managed. Next. So in terms of selecting the right biological therapy, once we've confirmed the diagnosis, they are uncontrolled, they have moderate to severe disease, and there may be contraindication for other medications, then we would also look at their comorbidities and consequences. We would have a shared decision-making tool to discuss with them risk benefits and, of course, the potential outcomes that they might expect. We would look at their biomarkers and see if type 2 inflammation is likely. We would inform them of the treatment options, of course, and then we may select surgery, biologic, and again, this may not necessarily be mutually exclusive, and then long-term perhaps select a biological drug that would be appropriate for them, considering their comorbidities, the frequency of dosing, and the efficacy that we have perceived from clinical trial data, as well as some of those aggregate data we saw. So at this point, let's put this into implementation and see if our lovely Dr. Amber Patterson will take us through a case and challenge us.
All right. Thank you, Dr. Siri. That was excellent. Let's look at our patient, Tim, 32-year-old male, comes into your clinic, and he actually comes in not complaining of too much, but he brings his wife along. So you know there's a lot going on. And together they kind of bring up that he's had some ongoing severe nasal congestion that comes and goes throughout the day. And they're leaving for Europe this weekend, and they just really want to have a great time together. And the wife doesn't want him being miserable the whole time. So when we dig a little deeper about what kind of symptoms he's been experiencing, he says, really off and on for a while, I'll get this rattling in my nose, like snot's just kind of rattling around, congestion that comes and goes throughout the year, sometimes worse than others, hard to breathe when he eats, and recently has lost his sense of smell. He doesn't have any fever or any associated symptoms outside the nasal sinus area, but states that he and his wife are miserable because of his congestion. And his wife is concerned about polyps, which I thought was kind of interesting because that's a fairly educated guess. And so we were talking about what has he tried so far? He's tried Zyrtec, Claritin, Flonase. Nothing really seems to be taking the edge off. Even nasal decongestants the past few weeks aren't completely relieving the symptoms. Next slide. So we find out his brother has nasal polyps, which is why the wife was concerned about it. And his brother has had to have surgery to remove his polyps. In the last year, though, Tim said, I haven't had any urgent care visits, haven't had any emergency visits, haven't needed steroids for this problem. But then as we're going through the pharmacy fill log, we pull through that he did actually have prescriptions for antibiotics in August, September, November of 23, and then again April of 24. And when we bring this up, he says, oh yeah, that's right. I think I did have some sinus congestion and drainage that I did get some antibiotics for. He has a history of seasonal allergies and had been on allergen immunotherapy for a full treatment course. And he recalls feeling like that was beneficial, says that he got about 50% improvement in his nasal congestion while he was on shots. But he discontinued shots about 6 months ago, and it just seems like since then, things are just trending worse, especially in the last month when his nasal congestion has become very severe. Next slide, please. On physical exam, the things that really stand out are, first of all, just in general, his voice quality is extremely nasal. And then when examining the nasal turbinates, there is clear, enormous, glistening, semi-translucent polyp masses visible in the anterior part of the nose on both sides, originating from the middle turbinates. So these are severe nasal turbinates that could easily be seen just with normal physical exam without endoscopy. Next slide, please. Which of the following tests would you recommend for Tim at this point in your evaluation? Would you repeat his skin testing? Would you refer him out to see ENT for nasal endoscopy? Would you order a CT scan? Would you do all of these things? And are you guys seeing that question? Because what popped up for me was poll 2.
Yes, I think that they should go ahead and close that one out, and they'll populate poll 1 question.
Yes.
As we're talking about this, this was like reminiscent of so many patients I've seen, Dr. Patterson. And they're coming in and they're like, hey, these shots aren't working. I'm still congested. And the key piece of some of that history was like, oh yeah, I'm so congested, I cannot breathe when I eat. And I walk around breathing out of my mouth all of the time. And so I think his wife was very, very smart. But, just from the history alone, we're like, wow, we've got the diagnosis. Either that or he's got a foreign body. But certainly since he's not 5 years old, we don't think he has a foreign body.
Okay, we've got poll 1. So everybody, let us know what you would do next. We've got a few answers coming in. We'll give a little bit more time here. Okay, so looks like, do I need to close the poll for you guys to see the results, or can you see what I'm seeing? Are you seeing any results, Dr. Siri, on your screen?
Yes, I see some bars.
Okay. Okay. So
So
looks like about half of us are thinking, gosh, we need to do all this stuff. We need to skin test, we need to do endoscopy, get a CT scan. And then some of us say, why don't we just start with referring out for endoscopy, see what ENT thinks. And then another portion of us said, let's get a CT scan. Let's see what else is going on in there. Next slide, please. So you decide to do all of that, but his wife reminds you that they're leaving for Europe this weekend and you really need to do something now. So you decide to repeat skin testing while he's in the office, and it doesn't identify any relevant sensitizations. Next slide, please. So based on that, and knowing that they're here in your office really wanting some kind of solution quickly, and that you could take time when they get back from vacation maybe to do more, what would you recommend for Tim right now? Would you do a short course of oral steroids and reassess when he returns? Would you try a biologic? Would you say, listen, we really need to refer you out for surgery, so you're just going to have to make it through the vacation, and then we'll make you get you feeling better soon? Or would you prescribe a different medication? And poll 2 should be up now. So go ahead and put in your responses. It's always nice when they come in and say, hey, I need a quick fix, but I've got a really, long-standing problem. All right, looks like we've got a couple responses. So some people thought we should try a biologic, And then looks like the majority said, let's just do a short course of steroids. We can figure the rest out when he gets back. Next slide, please. So due to this urgency of the impending European vacation of a lifetime and grossly visible polyps on exam, you decide to do both, to start biologic therapy with a sample and do oral corticosteroid burst and send Tim and his wife off on their vacation. And you are pleased to hear upon his return that he had an amazing time. The treatments that you started really helped him enjoy his vacation, and he's really grateful for what you did. Next slide, please. But one of the things we need to do is to continue to follow with Tim to make sure that after those steroids wear off, that as we're on biologic therapy, that we're seeing benefit and that, we're not just setting on autopilot because of having an indication for nasal polyps. So with the EPOS and Euphoria update, there are some specific defined responses that we can look for in certain criteria, looking at nasal polyp size. So in Tim's case, with his polyps being visible on nasal exam, that's something we could look at. Looking at need for systemic steroids, improvement in quality of life, improvement in sense of smell, and reduction in the impact of other comorbidities. And the level of improvement in each of these criteria can help determine a score and essentially a response level. These types of things should be evaluated after 6 months and again after a year, because if by that point we're not seeing any treatment, we should be discontinuing therapy or thinking about alternative therapies. Next slide, please. It's 6 months later, Tim's back in your office, and he lets you know that he, had that first sample dose of biologic in our office, had a great vacation, came back, still didn't have things worked out with the specialty pharmacy, so we had given him another sample dose. It took 2 months to coordinate with the specialty pharmacy to arrange for approval and shipment of his medication. And during that time, his congestion significantly worsened to pre-treatment severity. However, he was eventually able to coordinate shipment, get things rolling, and once he restarted regular biologic therapy, his symptoms improved again. He has not needed steroids or antibiotics since being on regular, consistent biologic therapy for his nasal polyps, and he and his wife agree that he is in a good place. Next slide, please. I'll pass it back to Dr. Siri for some summary key points. Can we get the next slide, please?
Thank you very much, Dr. Patterson, for challenging us and thinking about all those different scenarios and what we might do for those patients. And it seems like all of us were pretty much in agreement with what we were going to do. So that's great. So in terms of summary and key points, again, those patients have a high symptom burden. We should appreciate the detrimental patient physical and psychological well-being of those patients with CRS with nasal polyps. And again, if you have one of those patients in your practice that has these classical symptoms, especially nasal congestion, facial pain, or pressure, we should have that high index of suspicion that they are CRS with nasal polyp patients and really deserve a referral to ENT, a CAT scan, especially if their skin testing is not that revealing, and certainly if they have failed some of those traditional managements that we think are effective for allergic rhinitis. So certainly effective disease management necessitates that accurate evaluation and certainly management of those comorbidities, identification, knowing that those patients have a higher risk of sleep apnea, have asthma that needs to be identified with spirometry yearly and potential exacerbations. They do develop more problems. If they are an older patient developing asthma, certainly we can look back into the sinuses. And there are certainly other concomitant things such as depression, anxiety, etc., poor work environment that results from patients who are not optimized on treatment. And then surgical intervention, a very important mainstay, also recommended and can be effective for people with uncontrolled disease, but there is frequent recurrence, particularly in those patients that we discussed who have certain risk profiles, especially if they've had other T2 inflammatory conditions that are burdensome. And then lastly, the newer wave of biological therapies, which are safe, precise, effective, particularly for those moderate to severe CRS with nasal polyp patients, a good alternative to repeat surgery and certainly to spare us from those repeated oral systemic corticosteroids in our quest for stewardship of both corticosteroids and, as Dr. Patterson mentioned, for also antibiotic overuse in those patients with poor disease control. Next. And on behalf of Dr. Patterson and I, we thank you very much for attending this CME talk on CRS with nasal polyps. Dr. Patterson, any final words?
I think you covered it. Thanks, everybody.
Thank you. Have a good evening.